Darafadachu. So I'll be talking on universal access to primary health care and the safety of obstetric practice, with a focus on obstetric practice. I know there are, I see many people from the ministry, from partner organizations, professional societies, and many colleagues. Probably I will just present a few points on universal access of primary health care with a focus on safety of obstetric practice, which I hope will help us initiate a possible discussion during the discussion time. And I don't have too much to say. And these are 5 points which I will be talking a little bit about primary health care, universal access to primary health care, what has been done so far in this country in relation to obstetrics practice in universal access to primary health care, and in doing so, what challenges were there, and what can we do if we have those challenges? What can we do? So, as you all know, primary health care basically is it's essential health care, and that should be based on scientifically sound and socially acceptable methods and technology. And primary health care basically is used to make sure universal health care is accessible to every individual and the community. And in primary health care, we need to make sure there is community participation in accessing health, and in doing so, the cost should be affordable. The individuals and the community should not suffer consequences of the cost. Primary health care encompasses all the 4 domains of health care, which are the preventive, promotive, curative, and rehabilitative services. And primary health care services can be disease-oriented, they can be service-oriented or community-oriented. These 3 orientations are basically taken as equally important for primary health care. And as you see it here, if we have a stool on which primary health care sits, and then those three orientations are said to be the 3 legs of the stool on which primary health care is sitting. So the disease-oriented one, service-oriented, and community-oriented, those are the legs of the stool on which primary health care is sitting. So those, for the primary health care to sit on the stool comfortably, the 3 legs of the stool should be equally strong, equally long. So one is equally important with the other. But in actual practice, when we see primary health care, the current primary health care, it is more of disease-oriented than service or community-oriented, followed by a service orientation, and the community orientation part is a little bit lacking. So if this is primary health care, so what is universal access to primary health care? Basically, as the name implies, universal access is everyone should be able to access essential health care. It is still essential health care services. In doing so, individuals should not be subject to the financial hardship of having access to essential health care. So why do we need universal access to health care? Because it contributes to better quality of life, contributes to global peace and security, and universal access to health is very important, because we all know health is a political issue in every part of the world. So what has been done so far in Ethiopia with a focus on obstetric practice in promoting universal access to primary health care with a focus on obstetrics? There are national documents developed at different areas, and in the past couple of years, there are improvements in infrastructure, human resource, health information system, and service delivery. Concerning infrastructure, many hospitals have been built, health centers, health posts have been built, And then the physical access to those facilities has been getting better in the past couple of years. Roads and other components of the infrastructure, electricity, water access is getting better in the past couple of years. In human resource for health, there have been accelerated plans and of human resource for health at different disciplines, like expansion of midwifery schools, starting emergency surgical officer training some 10 years back, the health extension program, which was launched in 2003, and on all those were contributing to the obstetrics service in the country to make sure there is access to obstetrics service at the primary health care level. So in concerning HR, the health extension worker which we have mentioned, more than 38,000 health extension workers, mainly female health extension workers, were deployed since 2003. And they focus on family planning and antenatal care, and since 2003, the maternal mortality, as you know, has dropped by around 43% from 740 to 420. This is the concerted effort of different interventions, not only of the health extension worker. I just took the number. The extension worker started in 2003, and then I just took the number, a change in maternal mortality ratio since 2003. Midwifery, there are around 12,500 midwives in the country practicing currently at the health center and hospital levels. They basically focus, as you know, on basic emergency obstetrics and newborn care. There are expansions of midwifery schools, and whenever we feel that there is a knowledge, skill, attitude gap in the midwives, in-service trainings were being conducted. And on top of that, catchment-based mentoring currently has become the one of the flagship programs, I think, of the ministry, and specifically the AMCH Directorate, to fill the knowledge and skill attitude gap in provision of obstetric service at the primary health care level. The emergency surgical officers, it was started in 2009. 200 plus surgical officers were deployed to primary hospitals to date. It's around 2 to 3 per primary hospital. And the emergency surgical officers working at primary hospitals, they focus on the comprehensive emergency obstetrics and newborn care. Since the training has started and deployment of emergency surgical officers to primary hospitals, there is an increment in volume of M&A services, and improving maternal and perinatal outcomes have been observed. Other cadres of health, like specialized nurses, scrub nurses, neonatal nurses, have also come into picture, which contribute to obstetrics practice or service at the primary care level. Anesthesia is the other one. Anesthetists are usually available at the primary hospital level, and then anesthesiologists are not available at the primary health care level in the country. And previously, we also had short duration CMOC trainings for general practitioners and health officers. One of the initiatives at the ministry level started a few years back was saving lives through safe surgery at the Medical Service General Directorate, who is specifically at Quality Directorate. And it was part of the Safe Surgery 2020 initiative globally. And it focuses on quality and safe, essential and emergency surgical and anesthesia care to be accessible as part of the universal health coverage in this country. And in this country, there is a high unmet need for essential surgical and anesthesia care in Ethiopia. In countries like Ethiopia, it is expected around 5,000 surgeries per 100,000 population is expected to be done, but the ministry's figures show currently we're conducting around 200,000 surgeries a year for a population of 100 plus million, where we're expected to have close to probably 7 million surgeries a year. We are currently conducting 200,000 plus surgeries. So saving lives through safe surgery focuses on creating access to safe and quality, essential emergency surgical and anesthesia care at affordable cost. And then this saving lives through safe surgery focuses on 3 procedures: the Bellwether's procedure, cesarean, emergency laparotomy for acute abdomen, and open fracture management. And figures show that from these 3 surgeries, cesarean section takes the lion's share. Around greater than 80% of the surgeries at the primary health care level are cesarean section. And as part of SALT's initiative, there is a mentoring in it, which uses the already existing EHAC platform. I have put this ESOG's involvement as a question mark because I was not sure how much ESOG was involved in the SALT's initiative. There are 3 major procedures selected, of which cesarean is more than 80%. But SALT, as far as I know, is being the project is being initiative is being run Surgical Society of Ethiopia with some involvement of the Anesthesia Society, I think, and Ministry of Health. I'm not sure about the involvement of ESOG. Probably I will leave it for later discussion. So what were the challenges? So some of the challenges, probably for possible discussion, the points I put here as challenges and what can be done are for possible discussion later. Then we're talking about obstetric safety at the primary health care level. At the same time, we're talking about universal access to obstetric services at the primary health care level. So to what extent can a core package of primary care functions or activities be identified? So what services can be, obstetric services can be delivered at the primary health care level? Who can deliver those services? I mean, that needs, a serious discussion. The other possible challenge, was a neglected demand-side solution to strengthen primary health care. Like we said at the first slide, one of the legs of the stool was the community orientation, which we said is lagging behind. So that is, one of the challenges. The roles of more and less qualified personnel, the one which I've already talked, who should give obstetric service at the primary health care level, and which services by which one. It needs some degree of detail look into. And obviously resource scarcity and inequitable and inefficient use of the already scarce resources, the other challenge. So what can be done? So like we said, we need to look critically into which tasks be delegated to the lower level workers, and that those lower level workers have to be carefully trained, and they should be well supervised during practice. And services, I'm referring to the obstetric service delivery, should be as per competency level. People should practice as per their prescribed competency level, so that the obstetric practice becomes safe. Then we need to have a minimum equipment and supplies per level of care. If it is a primary hospital, then we need to have equipment and supplies minimum needed at that level. We need to have sustainably functioning infrastructure, including the electricity and water system of the health institution. And it's good to have strong referral and feedback system. These are the points for possible discussion. Thank you.
Thank you very much for the opportunity. So I'll be talking on the role of research in promoting QED and something about national initiatives related with the implementation of research in QED projects. So these are the contents. Already quality of care has been addressed by the first speaker, and it is a degree to which health service provision improves outcomes. And another important point in the definition is should be consistent with current professional knowledge. It is a very key important to the right to health, and it is said to be the one which sets for improvement in equity and dignity. So there is a growing pressure to provide high quality care, but in developing countries it's a very much challenging issue to provide quality of care. So research is indispensable in promoting QED in reproductive health. This is because it evaluates and interprets the use, the cost, quality, accessibility, delivery, and organization financing outcomes of health services. And this will be very important in informing government officials, insurers, providers, consumers, and other important decision-making bodies related with health issues. So what is the role of research in QED? The first and the most important role is measuring. Unless you measure something, you don't have any room for improvement. So measuring is the most important component, the function of research. So it is a process of using data from different sources to evaluate the performance of health systems and healthcare providers against a recognized quality of care. But the problem is healthcare quality is not a single product like producing a car or something like that. It's made up of unusually diverse components, and the process which leads to good outcome is not well specified. So to address this, the Donabedian framework of quality analysis is applied in most research related with quality of improvement, which contains three important dimensions: structure, process, and outcome. And recently, patient experience is added as another important component of quality of care. So researchers generally, they measure the quality of care using the previous dimension, and 6 domains of quality are said to be evaluated using research, which was already presented in the second presenter, so I'll just pass that. It has 6 domains. So related with structure relates, generally it refers to the stable elements of a healthcare delivery system, and it's generally evaluated in research using quality accreditation or organizational accreditation. In our setup, it's not, there is no as such a well-known body who does like organizational accreditation. What is the effect of this organizational accreditation in terms of QEDs? It will address the equity component. For example, if there is inaccessibility of health services to some geographic areas, that might lead to an improvement in equity of health service or the infrastructure level. For process refers to what occurs during the patient-provider interaction. So it has 2 components: the technical excellence as well as the interpersonal excellence. So the evaluation of process can be done using the 6 domains of quality already presented previously, and it addresses all the 3 components: the quality, the equity, as well as the related with dignity, because in the process we also assess interpersonal experiences. So outcome, this is said to be the bottom line of healthcare quality assessment, and it reflects the effect of health provision in terms of patient long-term and short-term outcome. So it can be assessed using 3 important parameters using research. One is the generic approach. This is done at population level. So what we do is we just determine the prevalence, the incidence of diseases, and functional status. The other is the sentinel or adverse event, which address only health effects related with poor quality provision, and the third is individual level assessment, which assess health outcome at the individual level related with a single disease entity. So the fourth, as already presented, is the patient experience. Recently, that is used as a very important element of research in terms of promoting QED. So research shows that positive patient experience has a well-documented relation to clinical quality, and it is said that those patients who have a good experience in the clinical care provision, they are likely to be involved in their care, and they are committed to their treatment plans and they are more receptive to their medical services. So the other important role of the research is the development of guidelines. As you know, guidelines are developed based on high quality of evidence, usually synthesized through meta-analysis and systematic review. So this will provide a good ground for a standardized clinical care provision to patients. So the third and very important to address all aspects of the QED is the setting standards and quality measurements. So all quality measurements almost always begins with an evidence-based, which is extracted from a research. But how does a research become an evidence-based and then a validated quality measure that can be applied to multiple providers and health insurance is a question. So always a sound quality measurement, you use clinical research, usually in the form of clinical trials, okay? So for example, this is one example. A research is done that comes with, for example, hemoglobin A1C is important in the diagnosis and follow-up of patients with diabetes. That will set us an evidence-based, and then other research will be sought through systematic reviews that will lead to clinical guideline development. That clinical guideline development and including other similar guidelines will lead to the so-called standard of care. Then that standard of care will lead to the development of a measure related with the standard of the care. So that measure will be evaluated and finally it will come with a quality measure and that will be endorsed. So even the WHO uses all this approach in order to come up with good quality measures and standards. So generally, what is the use of these standards and quality measures is health facility leaders, planners, managers, providers can use all this to assess and monitor the availability of the resource, which is the equity part, the performance of process related with the quality, and also patient interaction, which will also address the dignity part. So it addresses all components of the QED related with improvement. So what will be finally the effect of the quality measurement? So it prevents overuse, misuse, underuse of healthcare resources. So in effect, it means that it improves effectiveness and efficiency. The other thing, it identifies what works in healthcare, because it usually it is used, it comes up with guidelines and evidence-based recommendations, research. And the other important thing recently is related with insurance payers and different health plans. It will also be useful for accreditation purpose, this research output. And also help consumers make informed choice that will related with dignity. And it also measures, addresses disparities in how healthcare is delivered. So it means it's equity. So since it addresses equity, it informs also policy. The other important, the fourth role of research is implementation of interventions. So implementation of interventions can be, synthesized through an evidence-based, systematic synthesis of evidence from the research on a different health issues. For example, effective practice and organization of care, which is a Cochrane review group. It focuses on different aspects of health provision, and it's planned to improve healthcare professionals' practice and organization of healthcare services. So there are different measurement methods for measuring quality of care that research use. So I'll pass that just to say something about health service research, because this is almost non-existent in Ethiopia, but in most countries, in developed countries, quality of healthcare provision is usually addressed through organizations which target health, specifically do health service research. So this is a multidisciplinary field of scientific studies that addresses a lot of aspects of healthcare provision. So the primary goal of health service research compared to clinical or medical research that it identifies most of the effective ways to organize, manage, finance, and deliver high quality care and reduce medical errors and improve patient safety. While usually medical research, it involves the development and evaluation of clinical treatment. So as a final point, what is the role of research in KWD in reproductive health provision in Ethiopia? So I have tried to search some of the literature data, but the volume of research conducted is very limited. Most are cross-sectional, like 4 to 5 studies. They are related with CRC, 2 studies on health disparities. These are secondary data analysis from DHS, and 3 others on quality of birth services. Quality of ADC addressed in only 2 studies. Adolescent reproductive health is addressed the quality in 1 study, and quality of structural quality is addressed in only a single study. But there are no systematic reviews related with KWD in reproductive health service provision in Ethiopia. And another important thing, there is no institution dedicated for conducting health service research. But recently there is a noticeable initiatives in the national level to incorporate research as a core component of quality improvement. So one is the National RH Health Sector Quality Strategy from 2016 to 2020. So in strategy of stage 7, it states improve research and evidence for decision making. So it states that improving use of research and evidence for decision making for better health performance targets by 2020 set. So they plan to do research outputs on RH issue will be obtained from all research institutions, including universities, and utilized for decision making. And they are also planning for building capacity of research institutions to conduct problem area-oriented research. The other is RAC, Research Advisory Committee, which is already functional. The role is to prioritization of research for the most needed and part of healthcare provision, and to stimulate research and generate evidence gap. The other is to provide policy briefs based on research related with quality of service provision. Recently, maybe 2017, under EPHI, Health System and Reproductive Health Research Directorate is established, but so far it doesn't have any output related with KWD in reproductive health, but they have put their mission just to make, to set themselves like a health service research organization in Ethiopia, like in most developed countries. So these are the key points, the reference. Thank you very much for the opportunity.
Thank you very much for all the presenters. As you could have witnessed, this is a very extensive and in-depth presentation. Before I call our panelists, I think we owe them a round of applause, don't we? So just to contrast or to support what has been presented, we have 4 panelists from different diverse sections. As you see, all these are OB-GYNs, but we have the other partners to show. The first is the Minister of Health, our stakeholder, Dr. Mesaret Zelalem. I don't know whether she is here or not. Oh, she is here. So she is the Director of the Maternal and Child Health. So would you come to the podium? And the next is Dr. Ayele Dabebe, who is the Director and owner of Dosha MCH Center. He represents, we hope, the private sector. So I call upon Dr. Ayele. And the third is Mr. Mellis Takkala. He is the President of the Ethiopian Emergency Surgical Officers. So he has honored us with his presence. And Professor Yamane Brhan, who is he is our professor in public health. He has honored us today by being here to participate in this podium. And he is the director of the Addis Continental Institution of Public Health. So I'm sure this panel will have, as an audience, you will have many questions. We accept both vocal and paper-based questions. If you have questions, please write them on the paper and you can pass them through. I have just a few questions from the presentations that I have summarized. So, Dr. Mesaret, you have probably seen how Dr. Munir has crafted the first session. So what do you expect from the society members in research in promoting quality, equity, and dignity?
Thank you very much, and I really appreciate and for the all presenters, and I'm very much keen, and then it's my honor to be in front of you representing the ministry, in particular Maternal, Child and Nutrition Directorate. And for the questions, I think the ministry has working a lot on the reducing the maternal morbidity and mortality, not only maternal mortality and morbidity, but also neonatal and child mortality and morbidity. And there was a huge stride to end tremendous effort, and by like maternal mortality has been reduced to 72%. And the same is true for child and neonatal mortality. But nowadays we have been working on increasing the access and looking for like from east to west, south to north, and then access was the first question that was really answered in the previous decades. But now we have to critically focus on quality and dignity as well, because a community is requesting the quality, dignity, and inequality is also like is having in some of the regions. So there is a big disparity with reproductive health access and quality as well, so that the ministry is on board to work closely with the professional associations, in particular with ESOG, to change and or to dramatically move forward for the quality of maternal health and reproductive health. So we really request your kind office to work in collaboration with us, in particular with our ministry, and the presence of Her Excellency Dr. Leah was really give a big weight, because she definitely address what will be the future and what is our commitment to work closely with you. So this is really a critical time, because we're based on our HSTP, quality and equity, and information revolution is also the other pillar, so that we have to clearly work with you with information revolution and quality, equity, and then we have to also focus on the unreached one. So there is a big disparity among the regions, and the performance is very wide. There is a huge gap between when we see the emerging regions versus the agrarian or developed regions. There is a big gap. So with this, we need your expertise and your help as well.
Okay. So where do you see ESOG in that?
So we have RAC Research Advisory Committee, and with that you can be the part of that, because that's also based on the strategy document we have. We have already established and well-functional research advisory group, and then with that we need your expertise, your involvement. The other thing is you have been working closely with us with BMOC and CMOC rollout, so we need to further scale up and cascade it very well down to the community level. With that regard as well, we need your expertise. So in general, we need your technical advisory, technical support at all level based, and our office is open anytime.
Thank you very much, Dr. Masarat. So considering access to reproductive health, and I think we cannot access all. I mean, when we say the marginalized, the poor, okay? But where is the role of the private practice? Where is the role of the private practicing OBGYNs in increasing access? Dr. Agela, will you respond to that?
Thank you for giving me the chance, the opportunity to discuss on this topic. Mostly ignored the contribution of private sector. And just as point of clarification, this is just my opinion, and it is not something research-based, and also I am not representing, like this is not a consensus statement from OBGYN practicing at the private sector. I can say private institutions can have significant role in promoting quality in reproductive health, especially in improving access to most of the people. And observing elements of quality is not only the ethical point for private practice. It is a matter of survival. It is a matter of survival in that because one can't abuse client and stay long in the market. That not. So we have to observe elements of quality, as stated by WHO. It has to be safe, it has to be effective, it has to be efficient, because we don't have extra budget. We have to raise all the elements, and it is also equitable. And for us, every client that comes to the private sector is our social. So we treat them as provide equitable service. Also, from IPPF point of definition of quality, it has to be client-centered, and also we have to observe the client's perspective or client's right, and we have to observe the provider's need. And the cumulative of this will lead to a very good learning point for our health sector. That is why people who are willing to pay thousands when they get free service at the public sector for free. So observing quality is something highly exercised at private sector, and this could be like an input to the quality initiative as a ministry, and the private sector can contribute what they have done differently to attract clients to.
Thank you very much. So as you have started saying in the last sentence of your response, there is a growing interest in private-public partnership. It is one of, I think, the initiatives that the Ministry of Health and all stakeholders are interested in. So do you have anything to say on that? Do you envisage a partnership between the private and the public in promoting reproductive health services?
Yes, the private clinics or private centers and institutions has a lot of role to play, and also private, the partnership will enhance our efforts. Private sector share a lot of burden from the ministry, and imagine all those deliveries that have been attended as a private sector. If they go to the public sector, it is again overcrowding. It is again loss of quality, and timely attention is one of the challenges we see at the public sector. So we share the burden. The private sector share a lot of burden. The private sector also complements what is not a priority for the government institutions, like IVF might not be a priority for Ethiopian government, but it could be handled. The client anyway need to assess those type of special care because that drains our foreign currency. So the private sector can also act in areas where it is not a priority for the government institution. Private sector also can serve as a referral point. If you just take my center, and I am located on the periphery, and most of the clients that come from health center or hospitals do end up in the center where they can't reach the bigger hospital. So some of the centers really refer to our institution for support. Private sector can also play a part in research, and we are concentrated, like the service is being delivered by 2 or 3 people or more people, but most of the time those are permanent residents there. So they can do more controlled study, as my Mokshi said before. So in area of research, we can also contribute a lot. It could be clinical research or client satisfaction survey or client preference and why they are there. So we can do a lot of research at the private sector. Private sector also can help in skill-based training, like if you go to the universities, they are overcrowded, and some of the students may not have a chance even to palpate or to do hands-on practice. So the private sector can contribute on that area. A lot. The private sector can also get involved in guideline and protocol development. And as a ministry, I think we have a 10-year-old obstetric protocol, and that is a time for revision. And if you involve the private sector, we can contribute hands-on skill or hands-on practice in addition to what can be downloaded. So there is a lot of things that can be done from private sector, and involvement of the private sector, I think, can play a crucial role in quality improvement. Thank you.
But access, when we say access, usually in reproductive health, we work in a team, in a team of health providers or reproductive health cadre. And quality definitely comes in between, and safety is what is the result of that. So I would like to ask Mr. Mellis, am I right?
Yes.
Yes. So where do you see the role of the emergency officers in like promoting quality access with safe reproduction?
First of all, I would like to thank the Executive Board of ESOG for inviting me to attend this historic event. Really, it's a great honor to be here and making a conversation in front of senior experts who have enormous experience, especially on the provision of reproductive health. To say something, some points on the primary health care. As it has already been explained by the presenter, primary health care is the first point of contact in the health care system, which is being given at the first level, which is at health center or primary hospitals, where most of our cadres, emergency surgical officers, have been deployed. So talking about universal access to primary health care and safety of obstetric practice is indirectly talking about the performance of the ISO professionals. So currently this universal access to primary health care and the safety of obstetric practice is not is the common global agenda to achieve the sustainable development of goals set by United Nations. Ethiopia is one of the countries striving to address this universal access coverage to the community by designing several strategies. Since the past few years, we have seen several activities done by Ministry of Health, like constructing health facilities, as it was already explained by the presenter, availing basic supplies, producing or introducing several initiatives, or producing new task forces, for example, health extension workers to address the health extension package, and to address the emergency obstetric care and surgical services by producing emergency surgical officers. So these are the initiatives taken by Ministry of Health, but despite of this all activities done, still there are numerous challenges being facing by on the provision of universal access to primary health care. Some of the challenges to mention, these challenges could be at different levels, at the community level, at health facility level, or at higher level, which means at a country level or global level. To say something on challenges at the community level, most of our ISO professionals reporting, still there is challenges at the community level, like poor health seeking behavior, delayance, or poor awareness the service available in that particular institution. These are some of the challenges to address the universal access or safe obstetric practices to the community. At the health facility level, still there are also complaining about the shortage and inadequacy of supplies in that facilities, and there is also frequent turnover of professionals from their site of deployment, and also poor motivation of staff is due to many reasons. One of the obstacles to address this universal access to reproductive health service in particular. So But coming to the at higher level, at the country level, most of the things is related with the financial constraints and also related with the policy issues. So these are the things that are affecting the provision of universal access, particularly reproductive health service, where majority of our cadres have been deployed.
So thank you very much. So do you see the role of you are the president of the Emergency Surgical Society, yes? Officer Society, yeah? So where do you see the role of the society working with the other RH cadres like ESOG?
Yeah, we have now currently 730 ISO cadres graduated from around 11 universities and have been posted in most of rural hospitals. As it has already presented by the presenter, significant changes have been noticed after the deployment of the ISO. Maternal days has been reduced by more than 43%. Neonatal days has been reduced. So, availing these cadres together with other professionals, changes has been noticed.
Yeah, I'm sure when there is task shifting, the evidence comes from the research, and including access to reproductive health and the issue of quality, equity, and dignity. Research is the pillar. But from what has been presented with Dr. Wendomo, if you have seen, there is little evidence that he could generate locally. So Professor Yamade, would you help us if there really that serious a gap in quality, equity, dignity in the developing country?
Thank you very much for inviting me to this panel. It's a great pleasure. As you know, research has to be an integral part of our practice. The revolution which started in the 80s, which is evidence-based medicine, has been advocated for the last 3-4 decades. But we need to ask where we are now. We have come a long way when we compare the research portfolio 3 decades ago and now. We see a tremendous improvement, but we have also a lot of problems that we need to address, and we need to address those problems. I think it's very important to underscore research is not a luxury, especially for poor countries like ours. It is a necessity. And also, research is not necessarily expensive. I can easily cite, we have not probably used 99% of the data that we generate in clinical practice. So it is actually the approach. It is about giving priority. Otherwise, it's not a very expensive venture, as I see it. It's also very important to have a multidisciplinary approach, like what Pareto principle says, the 80-20 principle. Maybe you have done 80% of the work, and in terms of producing research output, but the 20% is taking 80% of the time, so you give up. But for the other disciplines, the remaining 20% could be very simple. So if we collaborate, it is possible to generate useful information. But we have come also a long way in that sense.
Yeah, as has been presented by the 4 presenters, I think without evidence-based medicine and bringing the evidence into the practice, it would be very difficult to promote quality, equity, and dignity. So do you help us see the way forward between societies, professionals, government organizations, and individuals? How should we promote quality, equity, dignity in an evidence-based way using research as input?
I think the three issues, quality, equity, dignity, very sensitive, very complex, very difficult issues. And the basis to address those issues is actually to generate information, to generate evidence. Where is the problem actually? You hear a lot of you know, criticism even in the public media without any foundation. Where is the problem? Is it the supply side or is it the demand side problem? To what extent are these problems you know, curtailing, providing quality, dignity service? We don't really understand them. And these issues, although they have some universal nature, they are unique to our context. So some of the issues are actually context related. So we cannot just copy from textbook and say these are our problems in Ethiopia. The problems in Addis Ababa are different from the problems elsewhere in the country. So the primary issue we need to address is we need to work together, all of us, you know, to generate key information that are necessary to address these problems. So blaming each other is not going to help. And then, you know, we have to develop interventions based on the evidence that we generate. So that's, I think, probably the way forward.
Very much. Thank you very much. I think before I take a few questions from the audience, I think we owe them a round of applause for the panelists and the presenters. So before lunch, I know lunch is approaching, but we have still 15 minutes.